Now we're going to change gears. Before we do that, I'd like to acknowledge the presence of Professor Wendell Abel, who is now with us, and Dr. Christopher Charles, who is one of the members of the CARIMENSA team. So we're going to change gears now. I'm going to ask Dr. Robertson Hickling to take over the next phase, and she will be the chairperson for this time.
I'm not asking. Thank you. We now move on to session 2, which looks at the psychopathology of trauma. And we're very fortunate to have Professor Guzder, who you were recently introduced to, speaking about attachment disorder and complex trauma. And I think you heard Professor Sams Vaughan raising some issues which no doubt will be addressed. And then we will have Dr. Debian Chambers, who is a counseling psychologist and who currently works at the University of the West Indies Health Center, who will look at perhaps some more, I guess, conceptual issues about where psychiatry and trauma come together. Okay, Professor Guzder.
Thank you. I'm waiting for the technology gods to join us, and because I'm switching to a Mac computer. I hope that's okay. I just wanted to say about the presentation we had from Dr. Sam Vaughan's data. That was just stunning data. There's very few places in the world that we have that kind of data. So, you know, this is unbelievable, and really, it's amazing work. So I want to just say I'm really astounded at this. And when I started working here in 2005 on the Dreamer World initiative with Fred and Hillary and the team, we didn't have that data. We just knew that there was tremendous amounts of violence and exposure and risk to the young children. And many times I would present the data from Dreamer World and the positive results of that scaffolding that we chose to do from 8 years on for children who couldn't read and were out of control. And people would always say, well, tell us what the trauma level is of those children, because they were astounded at the good results of the Dreamer World project. So I just want to say that just as you reported from Tennessee, okay, I'm working with children who did not get early intervention, who have landed up being failures of treatment, and that I have to work with them later as school-age children from 5 to 12. And we have a completely family-based orientation, but what's missing is the work with the community. So I want to honor Frantz Fanon, first of all, in being invited here and try and circle around to some of the things that are relevant from the two speakers before us. I was very honored to hear their work. So, as you know, 1863 marks the emancipation in America, and this is as relevant to us in Canada as it is in America, because then you would think there begins the struggle of equity and the injustice that you spoke about is embedded in a system that we still are living with. And Canada always congratulates itself that it isn't like the Americans and we don't have Trump, et cetera. But we're close behind in different kinds of ways, okay? I won't even comment because I'll get crazy. So, But what Frantz Fanon did, I mean, I remember when I was a 19-year-old student at McGill, we were reading Frantz Fanon because this was like the great hero for us, the first person who really wrote about the fact that our experience as visible minorities is very different. Whether we are privileged in the post-colonial era, we didn't think it was very post-colonial in our experience, but we weren't allowed to say so. It's very interesting that now I'm in my 70s, I'm allowed to say that it isn't different, and it's certainly, there are huge issues for us. So Frantz Fanon is the one who really said visible minorities experience the world differently, and colonialism has had a tremendous impact on us. And it's only really recently that, and we were pervaded by this kind of influence. I'm a psychoanalyst, but the influence of psychoanalysis and the psychotherapeutic model that elevated the therapist to this position of neutrality is one of the great delusions of our time. And I'm going to say that as a family therapist, as a child psychiatrist, and as a psychoanalyst. When we really look at the cultural and social person in terms of identity and not just the psyche itself, we have a vast richness. And one of the premises that's come out of the last few years of working with the post-colonial era is the concept of cultural safety. That is, if we do not provide institutions and care and engagement that is culturally safe, and this is particularly true for the Black community and the visible minority community in North America, we've lost something incredibly important to therapeutic alliance, and this also comes out of Fanon. Fanon, for me, didn't articulate it with those words, but the Maori people in New Zealand articulated this in a very interesting way. And I think that we have to look at how we've moved from an individual focus of the psyche and an individual focus on what we do as therapists to what we've now understood as intersectionality. That is, that there are many dimensions and perspectives that have to come to really understand suffering and what ACE means. Okay, it means a social reality and social disadvantage. It means a construction of the person. It means gender. It means many, many things. So intersectionality theory was very important. The concept of social suffering that Arthur Kleinman gave us is incredibly important. The fact that family and systemic work started and gave us a very different model of intervention. And I'm a family systemic therapist from the time I started my training. And I wanted to say this as a comment that we have had to fight very hard, and I have to say all across Canada, very few people, very, very few institutions, and I can number them on my fingers here, are doing training in family and systemic therapy. So in fact, very sad to say, even though you've been very explicit today that you're a family-centered child psychiatrist, as I am, we are a minority. We are really marginal. And training people in our teams to be family and systemic therapists is something that really needs to be addressed. Not only the community engagement part of this and the social dimension of it, but the fact that it is appalling to me that the adult psychiatry people have not yet understood that they need to be on the continuum of what we do. And that's what this wonderful data is really telling us. We have to think about family systems. And we also have something very important going on in pediatrics and family medicine. That is the evolution of what we call social pediatrics, and the family clinician as one of the central points in the first time that we see children and families, and the amazing opportunity that gives us to do the intervention that the research is telling us has to be done. Ought to be starting in pediatrics and family medicine, being funded in a different way, and still the governments are really not getting it. So cultural safety, if you haven't heard that definition, is any action that diminishes, demeans, or disempowers the cultural identity and well-being of the individual. That's come out of the work with the Maori in New Zealand and is very important. And if we want to talk about the agenda that, that the research that we just saw underlines, that attachment trauma and what I would call soul murder, which is the legacy of slavery. And this island in particular represents a kind of living experience and laboratory of dealing with that in every facet of its being. Is a legacy of how something that happened hundreds of years ago, which broke the family and which disempowered men to be with their children and which made a kind of survival that forced women to become it became a matrilineal experience, and we see the result of that in the research. This legacy has had a huge importance in the reimagining that women had to do also about what parenting is and what their own identity as parents is, and the private identities that they carry within themselves. In fact, there's a lot of research, at least we have seen in Canada, where Black women suffer depression and manifest depression in very different ways than host culture clients, and actually suffer more depressive illness than host culture people. And the Canadian data is very clear. But it doesn't get treated, it doesn't get diagnosed, and it doesn't get picked up. Very important, because we already know in terms of adverse effects in parenting that a depressed mother and poverty are the two biggest factors in terms of undermining the well-being of children. So we have very high rates of monoparental families and the stressors that creates. Now, I'm a child psychiatrist in Montreal, and I actually got very engaged with Hillary and Fred when they came to visit us at McGill, because I was treating Caribbean families and I had never been here. So this is very important too, that you may live in the north, but what's going on down here or in the south is very relevant, because the entire world is in urban Canada and America. And so I was being taught by my families things which I began to understand only when I came back to the Caribbean. And Nancy Boyd Franklin's work as a family therapist with Black families has underlined how important it is, this point that was made earlier. All of our research has focused on mothers, and we have completely ignored fathers. And we see that the boys, my practice I run a day hospital. I've been running it for, many, many years, and Stephen works in the day hospital with us. It's just, we used to be 99% boys, because who gets kicked out of school and who causes the most aggravation and who has the most externalizing disorders? It's boys. And so boys were like really vulnerable, and they're father hungry, and they're very affected by the realities of single mother families, and migration and the non-reunification of families is a huge and difficult agenda for our Caribbean children. Now I have to say the number of girls in my unit is going up steadily. So now I see many more aggressive girls than I used to. And again, I'm thinking about the Caribbean families that I'm seeing. I'm seeing very aggressive girls and very aggressive boys. And underneath the aggression is a lot of depression. Okay, so if you once you resolve and hold these children and you actually start intervening with their families, you see them switch from absolute rage and acting out to somebody who can tolerate their sadness and start to work with it. It's always a step up when my boys become sad, because it takes a lot of maturity to be sad. A lot of maturity. So it's an epidemic. The other thing is, when we talk about Black families in Montreal, we're not talking about the Caribbean alone. We're talking about African American families who migrated up after slavery. We're talking about Blacks who were there even before slavery issues in America. We're talking about African migrations. We're talking about very heterogeneous communities, and they have very different constructions, and the stereotyping of a community as a Black community is in itself, to me, very dangerous. So that what I prefer to focus on is that everyone has a personal narrative, and that personal narrative has dimensions which include the essence of their life and their psychic development. So in Montreal, the Black community in the English side is 5% of the population, but it represents almost 30% of placements. So the children in those communities are very vulnerable. They also get reported more often. And even though you would think at this point that we'd be much more sensitized to racism, our system is not. I mean, we have real problems with institutional racism, whether it's police, social service, or schools. And as I said, depression is depression in the Black women I've seen mainly manifests as irritability very often, and withdrawal, social withdrawal and isolation, and the inability to use a support system. So these are women who are not used to being taken care of. The message is always being do it yourself or you're strong, and the result is that they bury their depressive illness, and the person who receives the impact of that is their children. And part of the coercive punishment, apart from the legacy of slavery and the displacement of harsh punishments to prevent your child to do things, is also, in my opinion, related to this survival mechanism of you can do it yourself. You're a strong woman. This message of the strong woman has two sides. Okay, so to help somebody engage means they have to be willing to enter into a relationship with you where they are allowed to be vulnerable in treatment. And that may be easier for them on a community engagement level when they know that there are other mothers and that they are not alone, which is why we need to talk about that. Besides the overrepresentation of children in our system, in the foster placement system, we also have a lot more of them in prisons. And America is just, I mean, it's a terrible tragedy, and we don't have to go into the terrible numbers that we're seeing of young men in prisons. Then there's the issue of barriers to access. So the government is very comfortable that minorities do not walk through the office doors of the clinics. And one of the great mythologies is, oh, well, the Black community and the South Asian community and all these communities, they don't seem to have much mental illness because they never come to see us. The reality is they don't come to see you because they don't feel culturally safe to walk through your doors. And so the Black community has been working for years at how do we outreach our own people, and they brought in things like strengthening families and developed parallel systems of care because the community said, we don't trust the institutions. We don't trust the schools, and we don't see ourselves there. We walk into a room with a team. We don't see any Black people on that team. And so when we have Black therapists, this is a very precious agenda, Black teachers, etc. So if I'm not represented in the system that is caring for me, that has a huge and undermining effect. Advocacy has become really an important ingredient in actually training people and understanding that we're talking about human rights agendas, just like when I see a lot of refugees and migrants in my practice, in my work with the Cultural Consultation Service. You cannot separate good psychiatric care with children from human rights and advocacy agendas. And you cannot separate it either from being open to doing the very messy collaborative work that we heard about in our first keynote today. That is, you have to go to the people and you have to be available to visit a school and visit a community. Child maltreatment is a huge agenda for us. And what we're really looking at is how do we increase parenting capacity, and how do we outreach to children as scaffolding so that we can give them things that they need at various developmental windows. There are opportunities that come up at certain times in children's lives. The first 1,000 days is a huge, important area. And in fact, in building on the presentation we had before us, it would start in pregnancy. That is, any kind of early intervention really ought to start in pregnancy, because postpartum risk amongst immigrant women is much higher than the host population. It's very well documented. And the first 1,000 days has become the favorite funding policy for Bill Gates and various other people. So the other skew that's happened is that now, because people understand how important that is, the skewing politically of funding always goes with the latest fad. And one of them at the moment is we should catch them early, which I'm absolutely in favor of, but then they leave out school-age children and they leave out adolescents. And then finally they catch up and they say, oh my God, we have an epidemic of suicide amongst adolescents or delinquency, and then a whole rush of money comes from another multimillionaire. This is another trend, by the way, in public policy that we've been seeing. One of the things that's happened then is to look at the agenda of how we actually have to think of everything has more than one story. You only get one story in an assessment, you're really missing the boat, because there are many narratives that build up how people shape their lives. And one of the agendas of therapy is to rewrite and reframe that narrative. And the narrative that the child tells himself about who he is, smatification, for example, really Rex Netterford's idea, is you are a person, you are an important person, and that's a rewriting of an internal script. So how do you listen to a family that doesn't trust you in the first place, that is forced to come to treatment? Almost all my black families, they don't come to me because they want to come. They come because the school said, your kid can't come in my door, or because the youth protection said, we're going to place your kid if you don't go to see those people at the hospital. And we're a voluntary service, so that means we don't even take most of the people that come to us because they're not ready. So what we have is this huge invisible population who really need treatment or need scaffolding, but they're not coming through the doors of institutions. And that, again, is a very important issue. So poverty, migration, parental depression, substance abuse, and antisocial traits. I have 5 minutes. Oh, my goodness. So I'm really slow. Okay. I want to say, before I finish my 5 minutes then, part of the work that I've done for a long time is the evolution of personality disorder and how it starts way before age 12. Okay, so what we're looking at is all of, again, the agenda of neglect and emotional abuse being as important as physical abuse. Sometimes physical abuse is more easy to deal with than sexual abuse, which is horrendously difficult and scarring, and emotional abuse that is unremitting and neglectful. So as coercive as physical abuse is, these other agendas are the ones that are the bread and butter of personality disorder. So early evolution is a very important issue here. Dr. Hickling has done studies, again, on adult populations that say into the 40% in Jamaica. That's very, very astounding. Okay. So if we were to say, well, what are the other narratives of healing that are possible, that are preventive? Because we have to think about skills, the Black community in Montreal has invested in the family, Strengthening Families program, which is oriented to group intervention. It's very interesting that one of the primary agendas at the beginning is these parents do not know how to play with their children, and actually we start with the capacity to play and be with your child. They know how to coerce and punish and strengthen, and they're instrumentally good providers, and they're reliable, and they provide, but they don't know how to play with their children. They don't know how to engage to repair attachment disorder, which is intergenerational. So a great deal of our work has to think about the relationship between schools and parents feel terribly criticized, as people have said before. The Circle of Security program, which is an excellent program that's been developed for use with children. The Family Checkup, which is another very important evidence-based group, and the Webster-Stratton intervention. So there are already interventions out there that are evidence-based that give us prototypes which can be adapted and which are going to fit into the idea of what can a community do, and what has happened to many of our black families, as they go through Strengthening Families program as groups with their children, they'll go through it several times because they will refuse to go into the other kinds of services. So we have children that ought to have been referred who simply don't have the trust. The parents just don't have the trust to go there. So I think because I don't have much time, I actually prepared all these family stories for you, but I think I don't really have time for my family stories. I would like to tell you that Strengthening Families, at least if you look it up and you look at the program, it's a manualized program. You need to know that it started with substance abuse parents. That is, parents who are already substance abusers, and Kumfer had to do something for them. And again, this is a huge problem amongst our Caribbean families. Substance abuse is a kind of invisible agenda that children know about but that are not reported by parents. Just like they will never report to you that, yes, I took drugs during pregnancy, and you can see it written constitutionally all over their children. Because substance abuse really means preoccupation and absence. My body is here, but my mind and my heart are not here with you. And the agenda of that is, how do you change the epigenetic reality? Because if you can change environment, then you're going to affect gene response, and you're going to affect brain development. So again, we're talking about engaging parents in a way that is safe and non-coercive, and allowing them to develop something. And sometimes they cannot give these things to children. We have to prepare to do the scaffolding. And one of the places that we can do that is in schools. So school and daycare, school entry, and whatever you do before adolescence, before sexuality burgeons forth with all its agendas and the autonomy-driven agendas of the kind of North American reality of adolescence, those are invaluable opportunities for prevention. Those are invaluable opportunities to give our children the social skills and affect regulation skills that they need. And the arts are an invaluable channel to giving that help. Now, I won't give the rest of my presentation because you said my time is up. I'm sorry about that. But I really hope that if there are trainers in this audience, that you would consider expanding the family therapy skills of people that you train and work with. Thank you very much.
Hello, we have room for a question. Of course, we'll have opportunities to meet and discuss things after. Yes, could you tell us who you are, please? Give us your name. So, there's a...
My name is Joy Duncan, and I am a high school counselor in the Baltimore City Public Schools. And I do have training I'm an MFT, and I strongly subscribe to the whole systemic model that you mentioned. Now, one of my questions, though, is how does one, in this culture where the role of grandparents is so strong, how do we break that sort of generational pattern that comes over from the grandparents to the parents when we're bringing up our new generation?
I don't think it's about breaking. I think it's about how you engage. I have lots of grandparents in my office. And grandmothers, I have to say, if we look at, for example, what happened in South Africa with HIV, it was the grandmothers that saved an entire generation of children. And in my office, when I say a family system, I mean everybody who is important to that child as an attachment figure. So I'm very flexible about working with grandparents. And I don't think it's about the agenda of a nuclear family is necessarily the best way. I think that, in fact, the tremendous strength of an extended family, if you think about migration from Jamaica, is that aunts, uncles, grandparents are actually very key attachment figures. The problem is when these grandparents are themselves very damaged and move into very coercive parenting. We were going to present a case where the boy was left with his grandmother in St. Vincent. She broke his arms. She starved him. She would keep him in the house, from running outside by taking his clothes away. I mean, she was incredibly cruel to him, but she had also been very cruel to her daughter, who left that child there. And so the intergenerational problem was the problem of a lineage of agendas. And so I think it's about having compassion for how we speak to such a grandparent and how I can engage the child that was inside of that grandparent, and whether I can sell them a different way of being hopeful. That is, whether I can sell them that instead of that child being bad and needy and greedy, can I sell you that that child is dealing with certain kinds of realities that they simply cannot cope with? And how will we give them that shelter? Which is why churches are very important, and pastors are very important in our work, and all these other scaffolding people, because sometimes the grandparent will listen if the pastor says it. And sometimes I'll bring the pastor in to the unit. Okay, so when I say systems, I mean whole systems. I don't mean breaking, I mean repairing. And I don't mean, I mean reframing an attachment for me is more important. Reparation is much more important, and rewriting a narrative is much more important than saying, oh my God. I mean, how many times you say, oh my God, internally when you hear the stories of our children, but that's not what you need to, that's not what needs to come out of your mouth, right? What has to come out of your mouth in a way is, how do I reach this elderly person who has every good intention, okay, but has machete marks all over her arm because she wouldn't give up on her husband until he almost killed her, okay, and she's now raising an incredibly wild and out of control daughter, and she's already raised a couple of heroin addicts. Okay, so I have to have some kind of compassion for how I'm going to speak to her is very different than how I'm going to speak to someone else.
Thank you very much, Jaswant.